Good evening, sir. I'm Dr. Srinivas Kumar here. Can you hear us?
Yeah, I can hear you very well.
Thank
Good
you.
evening.
Thank you for agreeing to participate. And you, as I said, you are the opening batsman. I always felt a lot respected as a teacher, and now my alma mater, Sanjay Gandhi Postgraduate Institute. Here we have Dr. Sushil Kodali, the Luka Testa, Mukesh, and Dr. Eshpal with us. I will be also there. Thank you once again. I think over to Dr. Sushil and Luka for a few introductory remarks, and then we'll go on to your case. The pattern which we follow, we thought is, sir, we'll have 20 minutes with you, and 20 minutes we'll go to Pratap and Kollam, and then we'll come back for 10 minutes in the last to show the final results.
Okay.
Is that okay?
Right.
Thank you. Over to Sushil.
Welcome.
Hello.
Thank you very much.
Yeah. Okay, so you want me to speak now? And it's indeed a pleasure to join the TCT India today. And so I'm doing a live case, and with me is Dr. Rupali, and where is Ankit? Where is it disappeared?
So Dr. Ankit is also here.
So we are set up with a left main case, and I think the history you will say. Okay, Rupali is going to tell us the history.
He's a 56-year-old gentleman. He's non-diabetic and non-hypertensive, a chronic smoker. He presented with class 2 angina for past 6 months. His ECG was only right bundle branch block with echo, LV function was normal. His baseline investigations were normal with normal hemoglobin and creatinine clearance of 89. So his angio was done because having symptoms despite of optimized medical treatment. So can we have the angio, please?
Yeah, just show me the angiogram. Okay, so that's the first injection. As you see, there is some left main disease. This is eleocranial view, and this is something that I always do as first, because here you see the left main ostium pretty well. And as you see, the diagnostic catheter is getting into the coronary, and the mouth seems to be narrow, and then there is some disease beyond. We'll see further. Go on, please. Go on, please. I think this is unhooked. Just go back again. Yeah. Okay, so that's a better injection. So we have some left main ostial disease, and then beyond also there is some narrowing, I think you will agree. And then this is a dominant circumflex system. So the entire circulation is from the left. Next. That's the caudal view. Now you saw the left main in that one, and you see there is a ostial LAD very tight, and there is in fact a slow flow in the LAD, suggesting the critical nature of the stenosis. And then there are some more shots. So the LAD is filling slow. So that's it. Again, move forward. So that's the critical on the LAD ostium, and there is left main at the bifurcation and at the ostium. Next.
L6 of disease.
And LCX, well, looks okay. We see it best in the caudal view. That's the cranial view, and you see the entire left coronary is in fact narrow, the left main. If you see the size of the LAD and circumflexes, these are at least twice the size of the left main, and the left main has to be rather 1.5 times of these. So, you know, by going that, you can well appreciate that this is severe left main. Next, forward please. And of course the right is non-dominant. So that was the case. So what, any thoughts, if some, Sushil, Srinivas?
Some few important points which you told, sir. Ostial left main, it's very well profiled in eleocranial view, which we always tell. And then the size of the left main compared to the distal vessels is so small. That's how we tend to get an idea. Without imaging also, we always have a comparison with that way.
Yeah.
And the ostial LAD is also there. So what is your plan to cover entire thing through one stent with crossover?
Because the circumflex ostium looks okay on the angiogram, one could think of a crossover stent, and if the circumflex remains well, then we can accept it, or we can think of, that's a debatable issue, we can think of crossing it and doing a dilatation of the struts of the stent. But before all that, it's more important, I would like to, when we are doing left main intervention, it's very important that I must size these vessels by imaging. So that is what needs to be done. So the first thing that I would do is imaging. And in imaging, well, you could do IVUS or OCT either, but I usually prefer IVUS because OCT sometimes the ostium is not well seen. But so I prefer IVUS for the imaging of the basal disease and sizing of the vessel. Now, in this case, you saw the critical nature of the LAD ostial and the left main, whatever it was, all through, and slow flow in the LAD. So with that, I think just doing IVUS first go may not be a good option because you will start getting ischemia. So in a situation like this, I would think I must do some dilatation before I get onto IVUS because the disease severity is known. I am not concerned on that front. My concern is only sizing the vessel, and that can still be done even after I have done balloon. So what I in fact have done, if you can see, because after seeing that slow flow, otherwise I would have done the IVUS before. So I first put the 2 wires. So that can you see the angio? Can you?
Yes, yes.
There, yeah. So not so fast, please. Go back. So I put the 2 wires, and wiring LED was not easy. If you can show the fluoro, it takes a bend up and all, whatever. That's fine. So after putting the wires, I have done a balloon dilatation. And because it is ostial, I usually prefer a cutting balloon in this situation, which dilates these vessels without much dissection. So I have done a cutting balloon. Can you show this? That's the wiring, just to make it live, that's the wiring angles. The first wire went into circumflex, and the LED wire would not go so easily, you know, and then there was a test shot, and you see there is an angle there. So, so somehow then, it's going into the Ramus type vessel, which is a small one. Yeah, you saw that angle, so it's a pretty sharp bend, and then of course you enter. So that's it. So because after that we've done, so we've done a cutting balloon. You go on forward, please. Forward, please. So we've done the cutting balloon, and after cutting balloon, I put the IVUS, and I will show you the IVUS now. Can we now go to the IVUS, please?
Yes, IVUS is on.
Can you show the IVUS, live IVUS withdrawal? Okay, can you run it? These are still frames.
Yes,
Okay,
it's
running from distal end?
Left LED, sir.
No, it still has disease. So what you see here, the size of the LED itself is at least 4. You agree with me?
Yes,
it's a big, it's at least 4. And we're getting the withdrawals, we're getting a small branch coming in. There is some eccentric plaque in the proximal vessel also. And that's the circumflex trying to come in with the wires in there. The ostium of the LED has that disease, but I have already dilated it, so it becomes a little bigger. And that's the left main. And the left main is nearly 1, 2, 3, 4, 4.5 to 5. It's 4.5 to 5. And till the ostium there is plaque. Can you see there is plaque?
Yes.
From 12 o'clock.
Till the ostium of the vessel? Yeah. So we're just getting out of it. So that is it. So with that type of disease, because the circumflex angiographically, you can see how the circumflex looks after this. Come on.
Other important aspect of imaging is to assess the ostium of left main, how it LCX. If it is diseased, then you would plan to.
Yeah, I can do a withdrawal IVUS from the circumflex also. We've just done it from the LAD.
Yeah.
Can we see this angio better? Yeah, but somehow, you know, if you see the angio,
it looks
it
okay.
seems that the circumflex is big and it is okay.
Yes.
Yeah. Well, actually, I have a comment. I have to say that
Yeah.
what you did so far is pretty reasonable because I'm actually more than convinced that we should use IVUS for the left main evaluation, and particularly in this case, when you see, this is a typical diffuse disease of the left main in which you don't see a tight stenosis, but actually you see a long disease involving the osteal LAD. So I have to say that so far, this is exactly what I will do. I mean, considering that we need to clearly assess what the size of the left main, considering, as you said before nicely, that if you look at the circumflex, the left main must be even bigger than that circumflex.
Yes.
And of course, in order to understand which is the real size, if you don't do IVUS, you're just eyeballing. And that's absolutely wrong. But actually I have a question. Do you use IVUS in all your left main cases, or just in this case because
No,
it's
no,
pretty...
I use it almost in every case. Almost in every case. Left main, and I strongly believe that left main intervention should not be done without imaging. In fact, there is that Korean study from Park, one of the studies where only IVUS versus no IVUS, and he's shown a reasonably big difference of about 8% difference in MACE, if I'm not wrong. And I'm pretty convinced about it. Because and the other thing in left main is you have to assess left main angiographically if you so want to by thinking what it should be, rather than just trying to compare relativity. So you add the LAD and circumflex and say it should be at least 2/3 of the combination of the two. You know, that's a rough thing. In fact, we have done a study of IVUS size and angiographic size on left main, LAD, ostium, and circumflex. This is not published, and we have got an equation. You know, it's like a straight line equation, y is equal to mx plus c. So the true size will be nearly 1.75 times or 1.6 times the angiographic size plus 1.1 or something. Okay. So if you will come to that, if you try to calculate it, it will nearly come to whatever other calculations we have. But we've done that study, and doing left main imaging in most of the cases, you can get a good idea even on the angiogram. But I think for anyone who's wanting to do left main intervention or beginning or whatever, imaging is very important. That's what I think. So
one other quick question is, if you look at the osteal LAD in the left main, there's not, as you mentioned, both of you mentioned, there's not a lot of plaque, but there's negative remodeling of the vessel. Osteal LAD is negatively remodeled, a little bit smaller. Left main is. Does that change your strategy in terms of sizing? You know, the plaque burden. How do you factor that into the decision making?
Actually, the issue of how much it is negatively remodeled and how much is the plaque burden, because I am showing you the IVUS pictures which are post balloon. So you know, one can't be very sure of the plaque burden and how much has been squeezed or how much has been opened. So that is the only issue. But whatever it is, you have to get an idea what it should be. And going by that, I think I will size my devices and hardware according to that. You'll try to assess, seeing the normal LAD and the normal circumflex zones, what should the left main be, and then do it. I don't know whether you can you get what I.
It will not be totally normal in this case. This is a left dominant circulation. The ostial of circ will be affected, although not very significantly, but there will be definitely 30%, 40%, because distal left main is involved, ostial circ is involved, and left dominant circulation. This circumflex is equivalent to 2 vessels.
I think we'll proceed further, sir. In the interest of time.
We can proceed. Yeah, sure. So I'll choose a stent which is I think about 24 to, because I need to cover till the LAD. I will probably have a 4-0 stent right till the left main ostium, and then post-dilate the left main part to 4.5.
Yeah, this is the advantage of the later generation stents, which can be expanded proximally with a bigger balloon compared to previous generation stents. And we also have the advantage of LAD is also good sized here.
So I'm going to use.
Okay.
So let's see. So we'll use one of the newer generation ones, abluminous or something. Like Can I use a 420?
I guess the one question that's raised is it,
okay.
you know, should you routinely IVUS in both directions? Is it going to change your plan? Is it worth
yes,
IVUS
correct.
in both directions?
But here the circumflex looks very good, so I am not doing it. Otherwise, you could do it both the directions. We can. I thought I will put the stent and then expand the side holes and then do the IVUS on both the directions. That's what I was thinking. Yeah.
Particularly in this case, I guess that testing the left, let's say the circumflex with the IVUS will probably not add on much on top of what you already see, because you know what you actually ultimately need to know is the size, and definitely the size of the body of left main particularly, and then maybe afterwards you can check. But definitely looking at the anatomy, I would say that although there must be some kind of involvement of left circumflex ostium, there's not be a big of an issue.
True, and I guess the size discrepancy from the LAD insert is interesting here as well, right? Yeah.
Abluminous.
Dr. Luca, you have experience of this stent. I believe you can pass on some comments about it.
Well, actually, I lost the size of the stent. Which is the stent?
428, I think. What
428. Okay.
424. This is 424.
That's good for the implantation.
But anyhow, this is 24. So now what I'll do is I'll place the ostium first, and then wherever it ends. If it ends short, we'll have one more, no problem. Test.
Very important to check in the cranial view again, elevocranial and epicranial, because sometimes many of us tend to use caudal, but you may not assess the ostium right. That's how it is being positioned, the ostium carefully.
Angio, please. So you see, you're seeing the ostium very well.
Yes.
It is the true cuspogram. The sinus is there, and you see where the vessel is arising.
20 again.
Test, please.
And the worst thing here is to fall short of the ostium by 2 or 3 millimeters, because then you get the edge injury, restenosis, and you make the next intervention more challenging. So you need to be 1 or 2 millimeters out rather than risk being short.
Suppose by chance if you fall short, also always place well in the ostium first, and then distally you can tackle later if at all.
Test, please. I think this looks okay.
You can come here. Can you somebody give mic there?
Okay.
They're getting.
I have done it. Yeah. I saw it on the ostium and I think it was okay. And distal we'll see in the epicaudal view. So the pressure of 12. So this has actually medication only on the abdominal side, the stent. So the total total drug load is less, and probably with that you could have lesser thrombotic events. Or although now the stents are pretty good, I think, with those thinner struts and lesser drug. So can we?
You can tell me, sir.
Now you see this. Now you see this. When I placed it, you are seeing the artery all the way till the aortic sinus, and then it opens into the sinus. So there is no miss, and this is the best view I can tell you.
There's a question or comment from the audience.
Now, yeah, please. Looks good.
Yeah.
How's the circumflex? Looks good. It looks good. It looks good.
Yes.
The circumflex looks good.
Mm-hmm.
So we need to still do a 4.5.
Yeah, 4.5 can do the proximal dilation.
Can I have a 4.5 balloon? 8. 4.58, yeah.
Yes. Okay. Now I think now you will wire through another wire into the LCX and then post-dilate, or you will post-dilate, do pot and then...
no, I will post-dilate first. I will post-dilate first. The principle of this becomes a bifurcation. Agreed, there is the side branch stenosis is not there. But then what I do is post-dilate first, so that when I put the second wire, it doesn't go under the struts.
Yeah. So preferable to use a
so I will post-dilate first, and And this wire which is lying on the side doesn't create any trouble, I can tell you. And the other thing I wanted to tell you was I have done everything through a 6 French guide through the radial route. So, so some people might be scared to do a left main on a 6 French. So there is really, only thing is you cannot put 2 stents together, but otherwise you do 1 stent, 1 balloon, 2 balloons, it all works.
I think you can continue working, sir, and do imaging again post. We'll come back to you in the last 10 minutes.
Yeah, I'll show you the final,
we'll go to Dr. Pratap Center and come back to you. Over to Goel.
Right, sure.
Dr. Goel, sir, we are with you again. We are live.
Yeah, okay.
Okay.
So, as I told you, I had put the stent, you saw me putting the stent there.
Back.
You saw me putting the stent there?
Yes, we saw the picture after stent immediately. You are taking post-dilatation balloon. At that stage, we left you.
Back.
Yeah, so then what I did was I did a post-dilatation with 4.5 NC of the left main, okay?
Okay.
And after that, after the post dilatation, I have just crossed the circumflex through the struts and pulled out the other wire, the one which got gelled. Okay, so I still have 2 wires now, and then I wanted to do some imaging and see what the result was, how the stent has expanded and if there is any distal dissection or anything. So this is the epicaudal view which you see, the final picture which we have. So I will show you the areocranial also.
That's areocranial.
I think, yeah, that's the areocranial. So it looks all right and the circumflex looks open. So, but to confirm with imaging, this what we have done, then I did a OCT.
Can we have an eleocaudal view to see the LCX osteum once eleocaudal is done? Okay.
Yeah, sure. Let us see.
What size balloon did you post dilate the left main?
4.5.
4.5. Okay.
4.5. No, inject. Well, it looks okay. Actually, angiographically, it looks pretty good, I would say. Angiographically, it looks quite all right because there is no pinching at all. So you don't get any indication to do a balloon across the side branch. If there were some pinching, you could have thought of doing so.
One other thing shown clearly is the osteum is covered very well, and there is no left main. Now directly it is going to guide, and that shows.
Yeah, left main. You see the cuspogram, and you see again. Still here there is a little overlap on the sinus and the vessel. Can you make that out? Because this is eleocaudal view.
Yeah.
Some people considered eleocaudal as good for osteum, but this is what I teach all the time.
No, that's what we discussed. Cranial is always preferable for osteum. Yes.
Yeah.
Can you actually look at the, as you can see, this stent rendering is giving us an idea about the apposition of the stent. What is right? It means that the distance between the stent struts and the arterial wall is less than 200 microns. When you see the red color, it means that it's actually larger than 400 microns. So there is just a small segment, according to the OCT angiogram, that is still red. Can you actually look at that and show us? Because apparently there is a very small malapposition, or maybe under expansion. You see the red segment?
Yes.
At this point, yes.
Yeah.
At this point.
Because it can, you see, maybe 4 o'clock to 6 o'clock, there is still malapposition.
Yes.
Correct.
Actually, you can rotate it 3D and also confirm it, how it is looking.
Yes. Can you please rotate the image?
At that point, rotate the OCT at that point.
Can you rotate it?
This tool is very helpful because it gives you immediately an idea of what to do next.
Yes,
as you can see, there is still in the very proximal edge of the stent need for post-dilation. Maybe the 4.5 was not enough.
I think what's important with also doing osteal left main when you're IVUSing, make sure your guide is back, that you're imaging appropriately when you're seeing true osteum.
1.5 have to say you can anticipate
Because
that
otherwise
because the left main is so big
because
at the
we
end that
also did a withdrawal from the
4.5 can be
circumflex.
not enough.
And can you show the circumflex hole on the 3D? We can also see the hole of the circumflex on OCT. So actually post-stent OCT is, I think, good. Because sometimes OCT may not give you imaging till the depth or the 3-layer structure. So the sizing may not be correct at times, maybe. Although if you get the 3-layer structure, you can still get the sizing. And especially in left main. So what I usually like is if it is a post-stent, then OCT could be there.
Yeah, now you are seeing that ostium,
that
that bifurcation view or whatever you call the ostium of the LCX.
Yeah, yeah. Can you see that? Yeah. Ostium of the LCX is beautifully seen.
Yeah, this view, it also shows that the wire into the circumflex actually went through the proximal struts.
Okay.
Yes, this is a 3D, navigation and reconstruction of, according to the OCT, and it's the only way to clearly assess what is the position of the wire into the side branch.
Can you
Clear stent? Little back side.
I mean, OCT is a very powerful tool post-stent compared to IVUS, right? I mean, you talked about the benefits of IVUS pre and some of the assessments.
It's also very scenographic
It looks very catchy, attractive.
Do it. Clear stent again.
Beautiful pictures.
The only place where IVUS could be preferred is in the ostial involvement like this, where sometimes there could be
I think
challenge.
overall it's a very good result, but still there is something to do at the very proximal edge of the stent.
Other thing which is important while doing POT is to see what is the distal extent of the balloon going. You are supposed to just be onto the proximal part of the LCX origin. Do not cross the LCX totally, so that there will be less of problem of LCX when the left main stent expands well proximal to the bifurcation.
It's okay.
And I have to say that
You are taking 5 mm balloon. What are you doing, sir?
Okay.
You are taking a 5 mm balloon post dilating.
This is 4.5 only.
You did 4.5 already, no?
Only.
High pressure.
Yeah, because this is that was the proximal most end, and the pressure I used was only about 16.
Okay.
So I am trying to go a little higher on pressure this time, about 20.
Okay.
And I am slightly on the outer side, so maybe that will make a little difference.
I've had only a general comment. I have to say this is actually the beauty of doing imaging for the left main, because if you look at the angio, you will never anticipate that that stent is not very well opposed. You will say it's finished, so it's done. Nevertheless, if you look at very carefully with IVUS or OCT imaging, actually, you see these kind of things, and we all know how important is the apposition for the stent failure in that follow-up. So particularly for the left main, I would say we need to use more imaging overall.
More imaging or more OCT? So, but the area there was 14. At the area of malapposition, it was 14. What I mean, because again, what are you striving for?
OCT in the left main can actually give some hurdles because of the need for more contrast, the need for large volume sometimes because the left main is big, but also it takes some more skills compared to IVUS. But you know, in expert hands.
This what he wants to highlight is here we are started using one new type of material which is colloid, which is tetraspan, which is I learnt it from SGPGIMS during my live transmission in NIC recent conference. So instead of using a contrast, sometimes when you're worried about it, use this injection. You get very good quality images without the use of contrast. My nephro colleagues were also worried whether that is also
all the images
but it's okay.
Were without contrast. This is all we use Hemexil.
Tetraspan, sir. It's a colloid.
Yeah, tetraspan. You are taking that now, injecting?
Yes, sir. It's tetraspan only we're injecting, sir. All the runs we did with tetraspan only.
Okay.
Ready?
This is contrast.
Tetraspan. This is actually the co-registration because it's acquiring in the OCT, actually merging the OCT information with the angio, and it's actually the best way to look at the real situation after stenting. I have to say that there is no competition IVUS versus OCT, but it's just a matter of, let's say, technicalities, because if you are not used to use either one, of course you just rely on what you know.
Yeah, we are having a live webcast coming with Gary Mitch talking an advantage of each technology after some time. I think we'll hear more of it, but for youngster to learn, for novice to even imagine what it is, OCT is very easy to learn, and I think very catchy pictures. And with the three-dimensional reconstruction and it looks more user-friendly to learn. Only disadvantage is the contrast. If you can get away with it, I think it's better.
Yeah, and I have to say that particularly in the left main setting, where you may need to do the imaging plus, well, several times, the OCT can be a problem.
Several images.
Particularly when the patient has some renal failure and so on.
Yes.
But still, it's not a contraindication, of course. It's just a matter of, let's say, being used to. But definitely, if you look at the pictures with the OCT, well.
The other thing which you need to be careful is whenever the vessels are angulated, sometimes that tends to get separated while pushing. You have to maintain the coaxiality and then push it.
Right.
Especially when going into LCX osteum, sometimes it could create trouble, the OCT thing. Though the point of initial challenges were when you are threading it onto the wire, it was difficult. But the latest catheter, that worry is gone. Now it is easily enters without going into that crystal space. Another point of worry was whenever you're using such stents across, whether you will cross into LCX. Many times patients have gone when we had trouble distal LCX, we could easily cross with the latest generation stents into the LCX without much of problem. Even without pre-dilatation, we could sometimes enter easily. I think we have excellent demonstration, sir. I think we'll take one final picture and then see that red thing which is mala post is gone. And
auto calibrate. Enable. Go on. Enable. Okay.
Okay.
Go on.
One final picture, then Bhatia says we have to.
The picture is there.
Let's see whether it come on or not. Yeah, it's okay. It will get.
Are you? Because it gets you the stent 3D only when the pictures is absolutely.
See, this is one of the limitations of the OCT, because you have a lot of streaming of the contrast, because actually the OCT technology is based on the blood repletion, so you need to substitute the blood with the contrast. And of course in the left main, such a large left main can be a problem. Anyway, of course in expert hands, we can have these beautiful images, but let's say, generally speaking, that OCT can be technically complicated for left main assessment.
Pictures are not good.
Anyway, I think overall it looks good, sir.
I think that's technically.
Congratulations for excellent demonstration of usage of imaging. Both you have the luxury of using both IVUS before and OCT after. That's how I think it can be used, because initial assessment is always done with osteum, especially involved with IVUS, and then stent pictures are very well shown with OCT. Thanks once again for all the cooperation and help. He has been always a great source of encouragement. I think Hall is clapping you, sir. Thank you very much. We'll go to Pratap Center for last.
Thank you, Srinivas. Great.
Thank you, sir. Thanks.